Hello everyone, I am Dr. Selvalakshmi, Assistant Professor from Department of Periodontology, Vinayaga Mission Sankaracharya Dental College, and today we are going to see about endoperio lesion. Endodontics and periodontics, even though they are distinct fields, they are intricately connected with each other, and understanding their connection is essential for providing comprehensive dental care. So next we are going to see about the introduction part. The relationship between periodontium and pulp was first discovered by Simring and Goldberg in the year 1964, and since then the term endoperio lesion has been used to describe the lesions which are due to inflammatory products that are found in varying degrees in both the periodontium and the pulpal tissues. Then coming to the pathways of the connection between the pulp and the periodontium. Both the periodontium and the pulp have embryonic, starting from the development itself, and then anatomic and then functional interrelationship. Then the cells are ectomesenchymal in origin, and then the cells proliferate to form dental papilla and then dental follicle. Dental papilla, which is the precursor of the periodontium, and then dental follicle, which is the precursor of the pulp. And this embryonic development gives rise to anatomical connection, and these anatomical connections remain throughout the life of the teeth. And then the anatomical considerations in periopulpal diseases. First one, we have enamel, the deep pits, fissures, lamella, which are present in the surface of the enamel, harbor plaques of bacteria, and these plaques of bacteria initiates the caries lesion in the enamel surface, and which are most often the cause of pulpal diseases, as we all know. And the second one, we have cervical enamel projections, and these are flat ectopic extensions of the enamel, and they extend beyond the normal contours of the cemento-enamel junction, that is RCEJ. And this cervical enamel projections directly involved in pocket formation in an area where the accessory canals into the pulp may lead to endoperio disease. Then we have cementum, the fissures and areas of incomplete calcification which are present in the cementum, which when exposed by the disease, it serves as a channel for inflammation into the deeper periodontal tissues. And the fracture lines from enamel may extend into the cementum and also into the dentin. Therefore, this cementum, when exposed, it can readily permit bacteria to move from periodontal to the pulpal tissues, or else vice versa. Then we have dentin, we have dentinal tubules, and when the dentinal tubules are exposed in areas of denuded cementum, it serves as a mode of communication between periodontium and the pulp. And these exposed dentinal tubules may occur due to any developmental defects, any diseases, or else periodontal procedures. And then we have pulp. The degeneration of pulp may occur in cases of a caries, any restorative procedures, any chemical or thermal insults, and these regenerative products may reach periodontium also, and the degenerative products causes rapid inflammatory process, and this rapid inflammatory process results in bone loss, tooth mobility, and also sinus tract formation. And when the rapid inflammatory process progresses apically, it leads to periradicular lesion. But when the rapid inflammatory process progresses coronally, that is crestally, with crestal extension, it leads to retrograde periodontitis. And then we have apical foramen, which is the principal and most direct route of communication. Here we can see that. And bacterial byproducts and the inflammatory mediators in the diseased pulp exit readily through the apical foramen to cause periapical pathosis. And then pulp inflammation or pulp necrosis extends into the periapical tissues, and it causes a local inflammatory response that is often associated with bone resorption and often root resorption also. Then we have lateral canals, can be present anywhere along the root surfaces, and 30 to 40% of all teeth have lateral canals, or else we can call it as accessory canals, and the majority of them are found in the apical third of the root, as we can see in the images. Then we have palatogingival grooves, which are developmental anomalies of maxillary incisor tooth, and they begin in the central fossa, and then it crosses the cingulum and extends apically with varying distances. And these palatogingival grooves initiates localized periodontal destruction along the root surface, and bone demineralization follows the path of the groove. And when in cases of secondary involvement of the pulp, it shows symptoms of the pulpal diseases. Then we have etiologic factors. We have live pathogens like bacteria, fungi, and viruses. And then we have non-living etiologic agents also, like extrinsic agents and intrinsic agents. And then we have some contributing factors like a poor endodontic treatment, restorations, trauma, resorptions, perforation, and also finally developmental malformations. Then coming to the classification of endoperioral lesion, first classification which was based on the therapeutic pathways of lesion formation, and the first classification was given by Simon et al. We have primary endodontic lesion with secondary perio, and then primary perio, then fourth one is the primary perio with secondary endo, and then true combined lesion. It is the pictorial representation of the classification. First one, here we have primary endodontic lesion, and then primary endo with secondary perio, and then we have primary perio, and then primary perio with secondary endo, and then finally we have the combined lesion. And then the classification of endoperioral lesion based on the pathogenesis. We have 4. And the first one is the endodontic lesion, which is an inflammatory process in the periodontal tissues that is resulting from noxious agents which are present in the root canal system of the tooth. And then we have periodontal lesions. Here the inflammatory process are present in the pulpal tissues, and that is resulting from accumulation of dental plaque on the external root surfaces. And then we have true combined lesions. It is both endodontic and periodontal lesion, and they are developing independently and progressing concurrently, which meet and merge at a point along the root surface. And then we have iatrogenic lesions, which is the final one. They are usually endodontic lesions produced as a result of treatment modalities. Then we are going to see in detail about each class. First one, we have primary endodontic diseases. There is acute exacerbation of a chronic apical lesion, and the tooth with necrotic pulp may drain coronally through the periodontal ligament into the gingival sulcus. Here we have a tooth with necrotic pulp, and it drains coronally through the periodontal ligament into the gingival sulcus, and this condition mimics periodontal abscess clinically. But in reality what happened was, sinus tract from the pulpal origin opens through the periodontal ligament area. So for diagnosis, what we have to do is, we have to insert a Guttapercha cone into the sinus tract and to take 1 or more radiographs to determine the origin of the lesion. And when the pocket is probed, it is narrow and it lacks width. Then coming to the treatment part, root canal treatment is advised when the sinus tract extending into the gingival sulcus or furcation area disappears at an early stage once the affected pulp has been removed and the root canals are once well clean, shaped and obturated. We can appreciate the sign in the post-operative radiograph itself. Then we have primary periodontal diseases, which are primarily caused by periodontal pathogens. And in this process, chronic marginal periodontitis, here we can see this chronic marginal periodontitis progresses apically along the root surface, and when doing pulp test, it indicates a clinically normal pulpal reaction only. There will be accumulation of a plaque and calculus which exacerbating the periodontal diseases, and the pockets are deep in nature. And we have to be also aware of the radiographic appearance of periodontal disease that are associated with developmental radicular malformations. Then we have primary endodontic disease with secondary periodontal involvement. When a separating primary endodontic disease is left untreated, it leads to destruction of the periapical alveolar bone, and this destruction progresses into the interradicular area also. This progression initiates breakdown of surrounding hard and soft tissues, and then finally drainage occurs through the gingival sulcus, and there will be plaque and calculus accumulation which are exacerbating the periodontal diseases, and finally the apical migration of the attachment takes place and leads to periodontal diseases. Here is a classic representation of primary endodontic disease with secondary periodontal involvement in this mandibular first molar. Then we have primary endodontic disease with secondary periodontal involvement in other situations also. The first one is a result of root perforation during root canal treatment, or where pins or posts have been misplaced during a coronal restoration. And the symptoms are, in acute cases, we have periodontal abscess formation that are associated with pain, swelling, pus exudate, pocket formation and tooth mobility. These are in acute cases, and then we have a chronic cases also. In chronic cases there won't be any pain, but in acute cases we have pain. Then in chronic cases it involves the sudden appearance of a pocket with bleeding and probing or pus exudate. Then we have a root fractures, typically occurs on root reater teeth, that is often with post and crowns, and the signs are local deepening of the periodontal pocket to more acute periodontal abscess formation. Then we have primary periodontal disease with secondary endodontic involvement. The apical progression of a periodontal pocket may continue until the apical tissues are involved, and then the pulp become necrotic as a result of infection that are entering via the apical foramen or else the lateral canals. And in single rooted teeth the prognosis is poor, but in multi-rooted tooth the prognosis is better, because not all the roots may undergo the same loss of supporting tissues, and root resection can be considered as a treatment alternative in case of multi-rooted tooth. Then sometimes the treatments of periodontal disease can also lead to secondary endodontic involvement, where the lateral canals and dentinal tubules may be opened to the oral environment by curettage, scaling or surgical flap procedures. And it is also possible for a blood vessel within a lateral canal to be severed by a curette, and also the microorganisms can be pushed into the area during the treatment, and this resulting in pulp inflammation and necrosis. So we have to be cautious in treating a periodontal disease so that we won't end up in creating a endodontic diseases. Then we have true combined disease, and this occurs with less frequency, and this true combined lesion form when an endodontic disease progressing coronally. Yes, endodontic disease is progressing coronally, and then we have an infected periodontal pocket coronally that is progressing apically. So this endodontic disease that is progressing coronally joins with an infected periodontal pocket that is progressing apically, and the degree of attachment loss in this type of lesion is invariably large, so that the prognosis is good. Then we have the pathogenesis of periodontal lesion. The pathogenesis starts with accumulation of bacterial plaque on the denuded root surface in case of periodontal diseases, and this bacterial plaque accumulation induces pathologic changes in the pulp through the lateral canals or else accessory canals, and this process known as retrograde pulpitis, this process is known as retrograde pulpitis, which is the reverse of the effects of a necrotic pulp on the periodontal ligament, and as a result the pulp may undergo atrophic changes and also some other degenerative changes like reduction in the number of pulp cells, dystrophic mineralization, fibrosis, reparative dentin formation, inflammation, and finally resorption. Then coming to the diagnosis. This periodontal lesion refers to our old story chick and egg concept, where we won't know whether the endo lesion is causing the periodontic disease or else the periodontal disease causes the endodontic disease. So this is a dental chick and egg concept that is yet to be cracked. Then coming to the diagnostic procedures, first one is the visual examination. We have to examine the soft tissues, alveolar mucosa, and then attach gingiva to rule out any presence of inflammation, ulcerations or else sinus tracts. Then the teeth are examined for any caries, defective restorations, erosions, abrasions, cracks, fractures and discolorations like pink spot, which is an indicative of internal resorption. Then we have palpations and percussions. First one, palpations, which is a digital pressure to the mucosa covering the roots and apices, and a painful response is elicited in the presence of periradicular abnormalities or hot zones, but it does not indicate whether the inflammatory process is periodontal or else the endodontic origin. Then we have percussion. An abnormal positive response in percussion indicates inflammation of the periodontal ligament, which can be either of a pulpal or periodontal origin, and the sensitivity of the proprioceptive fibers helps in identifying the location of the pain. Then mobility. Tooth mobility is directly proportional to the integrity of the attachment apparatus or to the extent of inflammation in the periodontal ligament. Then we have radiographs, which are essential in the formulation of an accurate diagnosis, treatment plan and prognosis of a perioendo problem, and we have to use a probe, gutta perca or silver points or any other radio opaque materials, and this may expand the radiographic information that is obtained. Then we have pulp vitality testing, which is designed to assess the response of pulp to different kind of stimuli. In general, there won't be any response in case of pulp necrosis, and there will be moderate transient response in case of normal vital pulp, and then quick painful response in case of reversible pulpitis, and then lingering painful response in case of irreversible pulpitis. Then we have cold test, which is reliable in determining whether the pulp has got irreversible damage or not. Teeth with vital pulps will react to cold test with sharp, brief pain response that usually does not last more than a few seconds. But in contrast, when an intense and prolonged pain response occurs in case of irreversible pulpitis, and a lack of response indicates pulp necrosis. Then coming to the electric test, it is done to stimulate the sensory nerve fibers of the pulp to produce a response. There won't be any response in pulpal necrosis, and the positive response in case of either intact vital pulp or partially necrotic pulp. Then pocket probing, which is done to differentiate an endo and perio lesion. And periodontal probing can be used as both diagnostic and then a prognostic aid. You have to use a blunt calibrated end periodontal probe, which is done to estimate the probing depth and also the clinical attachment level, and it is used to track a sinus resulting from inflammatory periapical lesion that extends cervically through the perial space, and the presence of deep solitary pocket in the absence of periodontal disease indicate the presence of lesion of an endodontic origin, or else in case of a vertical root fracture. Then we have fistula tracking. Gutta perca cones or pre-softened silver cones are inserted into the sinus tract till resistance is met, and then a radiograph is taken, and this radiograph will reveal the course of the sinus tract and the origin of the inflammatory process, whether it is of a pulpal origin or else whether it is of a periodontal disease origin. Then we have cracked tooth testing, which is done by transillumination, wedging and staining, and it helps the identification of cracks and fractures in the crown portion. Then coming to the differential diagnosis between a pulpal and periodontal diseases. Based on some clinical findings, radiographic findings, we can differentiate whether it is of a pulpal disease or else a periodontal disease. First one, based on the clinical findings. In case of pulpal infection, the teeth will be mostly non-vital in nature and requires deep restoration, and the presence of plaque and calculus is not related to the disease progress, and there will be presence of acute inflammation, and the pockets are single and narrow, and the pH value is often acidic, and it is associated with primary or secondary trauma, and the microbial complexes are few in number. But in contrast, in case of a periodontal infection, the teeth will be vital in nature and the restoration is not related, and the plaque and calculus, which are mostly the primary cause of a periodontal diseases, and the inflammation will be chronic, whereas it is acute in nature of a pulpal disease, and the pockets are multiple and wider coronally, and the pH is alkaline, and trauma will be a contributing factor, and there will be a complex microbial presence was there in the disease. And then coming to the radiographic patterns, in case of a pulpal infection, the bone loss will be wider apically and there will be periapical radiolucency. But in case of a periodontal infection, the bone loss will be wider coronally, and most often it is associated with a vertical type of bone loss. And then coming to the histopathology, in case of a pulpal infection, there won't be any apical migration of the junctional epithelium, and the granulation tissues are confined to the apical part of the root, and the gingiva will be mostly normal. And in case of a periodontal infection, there will be apical migration of the junctional epithelium, and the granulation tissues are confined to the coronal part of the root, and it is mostly associated with recession of the gingiva. And then coming to the therapy, for a pulpal infection we have to do root canal therapy, and for a periodontal infection we have to advise periodontal treatment. Then coming to your treatment of a endoperio lesion based on each classes. First is the class 1, which is primary endo, the tooth in which symptoms clinically and radiographically simulate periodontal diseases. The teeth clinically and radiographically simulates a periodontal disease, but in fact it is due to pulpal inflammation or pulpal necrosis. So the cause symptoms which are seen in primary endo lesions are mobility, bone loss in the furcation area or adjacent to the crestal bone, and then pocket depth, tenderness to percussion, chronic draining sinus tract, and purulent exudate from the gingival sulcus, and also foul taste. And these symptoms indicates periodontal disease, isn't it? But the most significant sign that an endodontic problem is present rather than a periodontal problem is the patient won't have any periodontal disease or only have minimal periodontal disease in the mouth. The presence of pulpotomy, pulp capping, large restoration that is present close to the pulp, deep carious lesion or considerable diminution of the pulp canal space are a strong sign that an endodontic problem is present rather than a perio disease. But in a tooth with severe periodontal lesion with no caries, no restoration or else no fracture, and the teeth shows normal response to an electric pulp testing, then periodontal therapy is required. Then coming to class 2, which are teeth that has both pulpal or periapical diseases and also the periodontal disease concomitantly. The teeth has both pulpal disease and the periodontal diseases. And the criteria for diagnosis are the patient have periodontal disease in multiple areas of the mouth and also pulpal pathosis is present in the tooth of question. So, in this case, both endodontic and periodontal therapies are required for a optimal healing. And the prognosis of an endodontic portion of the problem is slightly superior because of little chance of recurrence, and the periodontal problem needs regular maintenance. And there are 3 types of lesions that can occur. First one, we have affected teeth that has 2 separate lesions, one periodontal and the other one is periapical with no communication with each other. And the second situation, we have a teeth with single lesion that involves both the perio and endo lesion, and that teeth has questionable prognosis only. And then a teeth with perio and endodontic lesion that were once separate but now they are communicated. So for this type of lesion, endodontic therapy is performed first and then periodontal therapy follows. In class 3, tooth has no pulpal problems but it requires endodontic therapy along with root amputation to gain periodontal healing. And the indications for root amputations are when there is a severe periodontal defect around only one root of a multi-rooted tooth. And we have some diminishing rule for this root amputation, which are problems with long-term success of a teeth that is treated with amputational therapy, and we can gain success in guided tissue regeneration itself. And then we have class 4, tooth that clinically and radiographically simulates pulpal or periapical diseases but in fact it has periodontal diseases. This is in contrast to class 1 where the teeth has symptoms of periodontal disease but it has pulpal disease, whereas in class 4 the tooth is clinically and radiographically simulates pulpal disease but in fact it has periodontal diseases. And coming to the diagnosis, there will be chronic draining sinus tract and it may lead to periodontal pocket rather than a periapical lesion, and the bone and soft tissue support is lost and the affected teeth is sensitive to changes in the temperature, and there will be tenderness to percussion, teeth mobility will be seen and then swelling, and periodontal disease present in other areas of the mouth too. And the prognosis is poor in this case if the periodontal therapy is not done immediately. Then we have some treatment alternatives which are indicated in case of a localized periodontal defect that is often associated with an endodontically untreated teeth or iatrogenic tooth problem. We have root resection or root amputation, then we have regenerative approach, and here we have non-bone graft associated and graft associated. First one is the resection, which involves removal of the affected roots or else in some cases extraction of the involved tooth. It is indicated in cases of root fracture, perforation, root caries, dehiscence and fenestration. Then we have bicuspidization, which is indicated in advanced grade 2 or grade 3 furcation involvement of a mandibular molar if the molar exhibits proper anatomic features and stability. Long divergent roots and bone restricted to the furcation area are ideal for bicuspidization procedure. And coming to the procedure, the molar is cut into 2 separate mesial portion and then a distal portion without the removal of the root or crown, and the tunnel like defect of the furcation is eliminated by creating a 2 separate tooth from a single molar. This is a bicuspidization. Then we have hemisection, which is surgical separation of a multi-rooted tooth, usually mandibular molar, through the furcation in such a way that the root and the associated portion of the crown is removed. We have to remove the diseased root and the associated portion of the crown, which is in contrast to bicuspidization where we won't remove the root and the crown part. And molars with advanced bone loss in the interproximal areas or the interradicular areas are not ideal for hemisection procedures. Then we have forced eruption or extrusion, which is indicated in a teeth with extensive decay or in cases of internal or external root resorption or else lateral perforation. And this forced eruption or extrusion serves as an alternative to sacrifice a natural root system, and this procedure is successful if the extrusion is only less than 4 mm. Then coming to the conclusion, a perioendo lesion can have a varied pathogenesis which ranges from quite simple to relatively complex, and a knowledge of these disease process is essential in coming to the correct diagnosis, and this enables the construction of a suitable treatment plan where unnecessary, prolonged or even detrimental treatment is avoided. Thank you all for your patient listening.